I'll now hand over to Professor Margaret Kingston, who will introduce our final speaker.
Thank you very much. I hope you can hear me okay. My camera seems to have disappeared. I'm afraid it was working when I joined. I don't know if it's been disabled at your end, but I won't delay by leaving and joining again. It's a real pleasure to introduce Professor Ngozi Osagie. I'm going to talk a little bit about her background and how she's ended up in the amazing position that she is. So Ngozi is a proud Mancunian doctor. She's from Miles Platin and joined a family of women, her mother and grandmother, who also spent their careers in the hospitals that now make up Manchester Foundation Trust. Her own medical career started as a medical student at the University of Benin, and postgraduate training took her through hospitals in London, UCL and Great Ormond Street, as well as across our region, Salford, Boothall, Wythenshawe and St Mary's, where she was appointed as a consultant neonatologist in 2002. I remember meeting Ngozi at an introduction for new consultants the next year, and we've been colleagues and friends since then, collaborating on various initiatives over the years. Ngozi rapidly established herself as a leader in her clinical field. At St Mary's Hospital, she has been the clinical lead, clinical director and clinical head of division for neonatal services. And under her leadership, the team has developed into the largest unit in England, delivering innovations, research and multi-professional undergraduate and postgraduate education and training. She was clinical lead for the single hospital service, the development that launched Manchester Foundation Trust from 3 previous hospitals across Manchester. She's contributed to child death outcome panels and is president of the paediatric section of Manchester Medical Society. For NHS England, she's taken on several high-impact roles, including chair of the Neonatal Clinical Reference Group, delivering essential work during the pandemic, and she is now the National Clinical Director for neonatal care. So she's the lead neonatologist in the country, driving forward the improvement of neonatal services and the transformation agenda nationally. For the Royal College of Paediatrics and Child Health, her national work has included driving innovations in CPD, in genomics, and she's a frequent expert guest speaker. Ngozi's expertise extends beyond clinical. She's also an expert in professional support for doctors. She was a long-standing GMC performance assessor. She served on several college committees, including revalidation and medical management. For 9 years, she was the Group Associate Medical Director for Professional Matters, and she's a Royal College of Physicians mentor for women in leadership. Ngozi has consistently used her expertise and profile to improve maternal and neonatal care for families of Black and Asian heritage, including her work with Embrace, the National the National Inquiry into Maternal Deaths, the Royal College of Paediatrics and Child Health Equality, Diversity and Inclusion Committee, the GMC Equality Forum, the Caribbean and African Health Network, the NHS England Race and Health Observatory, their Maternity and Neonatal Equity and Equality Forum, and she also supports a weekly video conference providing medical advice for members of the Black community. This is all really just a taster for her breadth of expertise, influence and impact. She has achieved so much and is an amazing role model and so worthy of this chair. Thank you, Ngozi, for asking me to introduce you. It is my pleasure to do so. And I am very pleased that we chatted at that new consultants meeting 23 years ago. Over to you.
Thank you very much, Margaret, for that wonderful introduction. So I'll just share my screen. And I hope you can all see that now.
Yes, that's perfect.
Thank you. So it is an honour to be presenting as a MAHSC Honorary Clinical Chair, and this lecture will take you through it's titled Inequalities in Health Outcomes and Neonatal Care, and it will take you through my experience as a neonatologist and some of the work that I've done looking at the impacts of inequality on neonatal outcomes. For me, life has been a series of sliding doors. It started off a Sunday walk on Great Western Street, which is just 5 minutes away from St Mary's. My father had come to Manchester to study, and he'd fully intended to return to Nigeria once he finished that. But however, the Biafran War delayed his return. My mother, on the other hand, had come via the Caribbean. Her mother was part of the Windrush generation who arrived from the Caribbean to England to help support the rebuilding of post-war Britain. I was born in Withington Hospital, and so my connection to both Manchester and its hospitals began at birth. Whilst my arrival in the world was connected to Manchester Foundation Trust, my family's connection has started even earlier and continues today. My grandmother, Ruby Innes, was domestic in Manchester Eye Hospital. My mother was a staff nurse and then a nursing sister in MRI, Ancoats and North Manchester Hospital. As I've said, I was a neonatologist, currently in St Mary's, but my training took me through RMCH, Booth Hall, North Manchester General Hospital. And my daughter is now an ST4 in radiology, and all my 3 children were born in St Mary's. I began my undergraduate training in Nigeria because my father did eventually realise his dream of returning to the land of his birth, taking his family with him. So I attended medical school at University of Benin, but my first professional contact with Manchester came when I did 6 weeks of electives on the Wellcome Metabolic Ward with Professor Peter Adams. I decided very early on in my career to be a paediatrician because I was influenced by the ability to really make a difference. We had a ward called the Children's Emergency Room. And what struck me was that following interventions by the staff, you'd see children that would arrive moribund and within a few hours were running around and ready to go home. And that had a real deep impact on me. Adult medicine just seemed to be a series of managing chronic conditions where you didn't actually manage to cure anything. My first contact was with neonatology, and I was exposed to 2 amazing neonatologists, Professor Fidelis Njokoma and Professor Angela Okolo. I was so impressed by their dedication, and again, the ability to make a real impact at a time when for everybody, a profound time in your lives is when you give birth to your children. My postgraduate training was Manchester and London. My first paediatric post was on Acorn Ward in 1992, and subsequently most of my paediatric training was in Manchester, apart from a year in London. I was really lucky because you don't often get to work with people who have had such a profound influence on your specialty. Jonathan Shaw was a consultant at UCH. His signal contribution was the invention of the percutaneous long line for intravenous feeding for preterm babies. And he did that together with real detailed research into the nutrient needs of preterm infants. And so it exposed me early on in an emerging career, I will say an emerging specialty of neonates, what could be achieved for these really small, vulnerable babies. Maren Thompson was a committee neonatologist I worked with at Salford with so much attention to detail that I imbibed that for the rest of my career. In 2002, I joined St Mary's Hospital as a neonatal consultant. Having done my training there, my imposter syndrome loomed large. I was the first female to join the team, but I was incredibly lucky to have 4 amazing colleagues, and my success as a neonatologist was almost guaranteed. Ian Dady was established the neonatal transport service, and it continues to today. Professor Malcolm Chiswick established the neonatal unit in the early days and fundraised from his front room to raise money for incubators and other equipments. He was the president of the Manchester Medical Society, and his presidential address in 2019 was Birth at the Margins of Viability, Ethics and Clinical Practice. a topic that still has relevance today. Doug Sims, a dedicated and wonderful clinician, really practical and sensible, with a wonderful sense of humour, and a penchant for meticulous data collection. He used to take Polaroid pictures of all our trainees, which really helped when 18 months later they contacted us for a reference. And lastly, Anthony Emerson was really ambitious and forward-thinking. And even though he retired from the unit 5 years ago, we still have quite a number of what we call Antonisms on the unit, where we say, well, this is what Anthony would have done. He established the unit database and an electronic prescribing, which outlasted him, and which was a bit of a problem because when he retired, we were really worried about if the database or the prescribing fell over, what we would do. But we continued to use that, and these were only retired when Hive arrived. So on to more about inequalities. So what does the oldest purpose-built primary school in Manchester, the Metrolink, and a single hospital service have in common? I'll start off with the school. Nelson Street Primary School was a school I attended. It closed in 2010. And at the time, the school invited past students to come back and for a sort of ceremony when they were going to close it and pull it down. And at that time, what was really evident to me was the health disparities between students who had left Miles Platting and those that hadn't. In 2016, the Manchester Health and Wellbeing Board commissioned a report by Sir Jennifer Michael, and it concluded that our city had an unacceptable variation in clinical outcomes, and that the existing arrangements for our 3 hospitals or services across Manchester meant that it didn't really serve the best interests of our population. There was duplication in some services, indeed there was triplication. And what we had was that depending on where patients presented, they had a variation in their experience, in the specialist services they would be able to have access to, and specialist opinions. To put it simply, patients with the same conditions, with the same severity of illness, were less likely to survive or more likely to have a longer stay in hospital, depending on where they presented in Manchester. And therefore, a single hospital service was conceived. I was really lucky to be the clinical lead for that project, one of 2 clinical leads for that project. I came into contact with a lot of counsellors, and this map of the Metrolink outlines the disparities in outcome across the city. And many of the counsellors I met would joke that each time they took the Metrolink down south, they gained a few years of their life. I always said to them, well, when you go back, you lose a few. And there were many benefits realizations of the single hospital service. And speaking about the ones that I found in neonates, once we merged, I remember visiting Wythenshawe Hospital and realizing about a third of the nurses that were there were actually nurses who were previously on the St Mary's Intensive Care Unit at what is now called Oxford Road. By merging, it meant that we were able to cull some of the number of nurses that left our service, because we're now in one big service. It meant that the difficulties we had in discharging babies to both North Manchester and Wythenshawe disappeared within a day. We're able to harmonise policies and took the best policies from all 3 sites, harmonising them to one. We're able to extend services that were not existing on some of the sites. And by having shared mandatory training and sharing expertise across the 3 services, it meant that we're able to improve things for all babies and not just a few. And these benefits were supported by a really fantastic divisional director called Chris Ashworth, who all you had to say was, this is what we need doing, and it was done. For those of you who are not aware of neonatal care, I just thought I'd give you a little bit of background. There are about 90,000 babies who are admitted into neonatal services every year in England. That's about 1 in 7 babies. 1 in 13 babies are born prematurely. The more premature you are, the longer you'll stay on the unit. But there are also a number of very valid reasons for term babies being admitted. And neonatal care, whilst, yes, it's my passion, but actually I feel it's really important because the impact of neonatal care carries on for many years. 50% of babies or children who are admitted to paediatric intensive care below the age of 2 have been cared for on a neonatal unit. And also the impacts of childhood mortality carry on up till the age of early childhood. We also know that currently that about 34% of deaths in neonatal care have modifiable factors, many of these sitting outside neonatal services, smoking, obesity. But it's not just about the babies as well, their families. 2 in 5 parents have anxiety or post-traumatic stress for those of them who have experienced neonatal care. And globally, there's a real burden. Neonatal illness is a leading cause of life years burdened by disability in the world. And these statistics are not changing. So there is a moral, financial and societal obligation to support neonatal services. And Jeremy Hunt, the then Secretary of State, recognised this imperative, and he set out a maternity ambition in 2025 for 5 areas, covering preterm births, stillbirths, neonatal mortality, brain injury, and maternal mortality. And part of this ambition was achieved. As you can see, over the next few years, stillbirths were reduced 23% lower, and neonatal deaths also 11% lower. However, this improvement was not universal. There were inequalities relating to deprivation. As you can see that if you're from a deprived background, you're more likely to have a stillbirth, and the gap for neonatal deaths is actually widening. In addition, if you are from a non-white ethnicity, you're also more likely to have a stillbirth or a neonatal death. So inequalities persist in relation to deprivation and ethnicity. And this is not just for stillbirths and neonatal deaths. It also relates to brain injury for infants in England with a diagnosis of brain injury occurring soon or after birth. 50% of babies in a deprived decile socioeconomic groups, 50% have a worse an outcome that is worse than those in more affluent areas. That again is the same for ethnicity. So compared to their white counterparts, brain injuries are over double in Black infants, 55% higher in Pakistani infants, and this persists for the non-white groups. This tartan rug shows you stillbirth rates by ethnicity and deprivation, with the bar sizes reflecting the percentage of each babies born in each deprivation quintile, and colours showing the stillbirth rate. And I want to draw your attention to the fact that whilst this is the least deprived quintile and the most deprived quintile for our families of non-white background, their risk of having a stillbirth, even if they're in a really affluent area, is still much higher than white women in a deprived area. If you look at Manchester, Greater Manchester or the Northwest, you'll see that even in Manchester, as demonstrated by the background work that was done before we had the single hospital service, that the least deprived areas in Manchester and the rest of the Northwest have double the mortality rate of children in the least deprived areas. So having established that prematurity is one of the biggest contributors to mortality, how can we improve outcomes for preterm births? So firstly, one of the things we can do is prevent, so minimize smoking. But once the babies arrive, try and optimize care as much as we can. And this is a bundle of optimal perinatal care that we've now established for preterm babies, making sure that they're born in the right place, they have deferred cord clamping, they get access to magnesium sulfate and steroids, and they're given breast milks in the first few days of life, because all these if you do all this, it has a significant impact on outcomes. However, again, the impact is worse if you are from a deprived background, and you can see that these are odds ratios for babies who are born in deprived areas compared to more affluent areas, and the same is similar, but for some statistics, mother's own milk, it is better when you look at ethnicity. So now that we've recognised some of these, one of the things I want to draw your attention to is what we can do about differential outcomes. In 2020, the BMA launched its specialist issue on race. It shone a really much needed light on the deeply entrenched biases in our healthcare services and structural inequalities that drive them. And in the wake of that conversation, the NHS Health Observatory was founded. This is an organisation with a mission of identifying racial inequality in healthcare. And this edition looked at patient outcomes and biases against disciplinary for doctors. It also called for an improvement of data and accountability, because if you have the right data, you can see what the outcomes are. And there was a follow-up edition 5 years later, which concluded that actually the NHS and healthcare do not exist in a vacuum, and that recent events risk reversing the small gains made in healthcare in relation to inequities, because there's quite a lot of pushback on the EDI programs and a general rise in an anti-woke sentiment. And this should not be ignored, but instead tackled. The RH, the Race and Health Observatory that was established, sees racism as a patient safety issue, and actually looks at how you can look to tackle some of this by looking at opportunities and raising questions of what can be done. So when it comes to maternity and neonatal care, one of the things you can do is look at the whole pathway and try and identify areas that you can have interventions that try and level up care. And actually, if you level up care for one area of society, that you generally level up care for everyone. So when it comes to neonatal care, what we know is that there's differential access to interventions. So referrals to genetic services, detection of jaundice, detection of cyanosis. So what have we done? So we now have a system where we have automatic referral to genetic services for detecting anomalies. We're working to look at how we can remove bias from clinical education. We are also looking at doing further work on the detection and treatment of jaundice. And in January this year, we launched a new national maternity and neonatal equalities dashboard that gives every provider access to its own data to see how they're doing. 3 years ago, the Race and Health Observatory did a review of neonatal assessment and practice in Black, Asian and minority ethnic newborns. And what they found was that there were specific issues with cyanosis and jaundice, and they came up with a number of recommendations. The main worry with jaundice is that it's a prevalent condition and very common amongst newborns. In developed countries, connectitis is really uncommon in babies who do not have specific risk factors. But what we do know is that if you are non-white, that the connectitis is far more common, and we feel that this is probably because it's more difficult to detect. So what can you do? So one of the things, in conjunction with colleagues in Medway and the RHO, is develop a 10 steps guide of how to improve recognition of jaundice in babies with darker skin. And this uses a consistent approach to look for jaundice, where to look, how to look, making sure that you can recognize it easily. It also provides points that you can use for escalation, and it addresses gaps in healthcare education. In addition, I received a grant from the RHO to look at effective monitoring of jaundice in the community, and we've just completed that work, and we'll be presenting it to the Race and Health Observatory in the coming weeks. The two areas that they highlighted in their report were jaundice and cyanosis. And cyanosis is very often difficult to detect by examination, but in many babies, and much more difficult if your skin's darker. And pulse oximetry is a simple, non-invasive method of accurately measuring oxygen levels, and it also provides you with an objective assessment. We know that mortality from congenital heart disease, that is the main contributor to cyanosis at birth, is much more prevalent in areas of deprivation and much more prevalent in Black and Asian babies as well. The National Child Mortality Database says that there's an excess of deaths in Black and Asian babies from congenital cyanotic heart disease. But measuring pulse oximetry will also give us an understanding of a number of other conditions that are important at the beginning of life. And we have now just come up with a framework for testing babies for pulse oximetry, which will be universal testing. And in March this year, it was included in the perinatal maternity incentive scheme. So all trusts will now be doing this. So what's the future? I'm a novice with AI, but this was an AI generated image. I said I was a neonatologist, interested in outcomes and health inequalities. I, however, couldn't get ChatGPT to take off the white coat and make me bare below the elbows, which is really important if you are looking at reducing infections. But the future is use of AI, but making sure that we take into account any inequalities and bias that are within AI. Genomic medicine is also really important, getting quick diagnosis for conditions and improving global access and ethics. So I started my story with 4 generations of my family connected to MFT. And a month ago, a 5th, my grandson was added. And so he was born in St. Mary's, so keeping tradition with being connected with MFT. Given the statistics on differential outcomes in pregnancy and birth of women of colour, I was overwhelmed with relief that the pregnancy and the birth went well and he's thriving. I'd like to end by saying thank you to the neonatal team at MFT, my colleagues at NHS England, my patients and their families, and most importantly, my husband, who's a gynaecologist, who supported me throughout my career, my daughters, my family and friends. Thank you.
Wow, that was amazing, Ngozi. Thank you so much. What a journey and a wonderful story. Thank you for sharing it. So can I start with the first question? Is that okay? So you've clearly got the opportunity to make some changes across the country now with the role that you've got at NHS England. What are your top 3 priorities of what you're going to operationalise in your term?
So some of them have already started. The pulse oximetry was a real win. We had tried to get this into the screening committee, but it doesn't, one of the things that they were concerned about was that it doesn't really meet the definition of screening. So having universal testing for pulse oximetry in the maternity incentive scheme is a real win. The second thing I'd like to do is improve the detection and treatment of jaundice, just because of the figures that I've dealt with. So those would be two of the things I'd like to do. And the third, I think, would be to make sure that the benefits we're getting from the Generation study, which is a study that is looking to diagnose early on a number of conditions by genome testing, is expanded throughout the country.